All right, y'all. Good to be back. Been a minute. No good excuse other than we've just been busy and haven't made the time to put these podcasts out there. So very sorry about that, but we're gonna do our best to really kind of get going here. Very quick announcement. So then we'll get on with today's episode where we talk about a couple different papers that came out recently. We have our Memorial Day podcast coming up. If you didn't listen to last year's podcast, would love for you to kind of go back and give those a listen. We put a lot of thought and time and effort into those, and it's something that we want to really kind of do year over year. And so we wanted to just put it out there. We've got a couple guests coming on this year that are going to be awesome, but also wanted to provide you with an opportunity to memorialize a friend or family member that may have lost their life serving our country in combat. So feel free to shoot us an email at info@owensrecoveryscience.com if you have a story that you would like for us to tell on air. We might not do it this year. We might do it, the next year. Just depends on how long things go. But wanted to just kind of get that out there and know that we appreciate the sacrifices of those that are close to you. So without further ado, we got some cool intro music and then podcast. This is the Owens Recovery Science Podcast. Ready to count us in, Johnny?
Yeah. Ons, dos, tres, cajote, or whatever he says in that U2 song.
Oh my God. That's definitely going in.
That's going in.
From the guy with a Mexican wife.
I think it's German. It's a U2 song. I don't know.
No,
it's not.
He says he goes from 3 to 14. It's the dumbest thing ever. 14 is 14. Yeah.
That's like
come on, Bono.
That was like the guy that we had in our unit over in Iraq. He ended up marrying this Hispanic girl. He's from Texas, but he didn't know Spanish, and his last name is Gomez. And so he couldn't read Spanish, so he had to have our other guy Maldonado read his letters from his fiance or his girlfriend.
No way! Oh my goodness, that's a slippery slope, right?
It was crazy. Yeah.
It says she is leaving you for
some other.
He needs to have his last name revoked.
Yeah.
Well, I'm going to be in France, and my buddy, his brother lives over there. So I reached out. I was like, "Hey, man, where's your bro live? Maybe we can hook up." And anyways, he's talking. He's like, "Man, the part of France you're in, you don't really have to, be hardcore and understand French because they all speak Spanish. So you can just speak Spanish with a lot of them." I'm like, well, hell, man, now I got to freaking learn Spanish. So I'm trying to learn.
Amazing.
All right, man. Y'all ready?
Yeah. No, back to the podcast.
If you want. Yeah. All right. Welcome back to another Owens Recovery Science podcast. It's been a minute since we've had the whole team on here. I think Ben said it's been like almost 8 months since he and Zach have been on one of our podcasts. So they might suck today. But Kyle and I are well seasoned, man. We've been knocking these bad boys out. Although we've had a break, man, for a little bit because life's been busy. So anyways, today we're going to break down 2 new papers that have come out that kind of build on a couple last podcasts that we've had. So I think it's going to be pretty cool. So we were supposed to record this yesterday, and I lost my voice because, I've lost my training legs, guys. I did 2 courses within 10 days, and then I couldn't speak for 2 days after that. So, I can't do it like you guys do it anymore.
That's your chronic load is way down, Johnny. You got to get your chronic load up.
I don't know. I'm old, man. I'm old. That's my problem. Look, here's how old I am. Today's a terrible day because tomorrow I got my colonoscopy. My first one ever.
Oh no!
I'm about to be violated. I'm on a liquid diet. I'm about to start cleansing the old system tonight. So Man, this is going to be rough. Yeah. My wife's been through one, and so she's been filling me in on how bad it's going to be this evening.
Great.
I'm worried because she's my ride, and she had one done because she had some stomach stuff. And when I went to recovery, her tongue was hanging out the side of her mouth like a dog, like a dead dog. So I took a picture of it when she was laying there, and that's bad enough. But then I sent it out to the family. So,
oh no. You have payback coming. Yeah.
So we're about to see. It's been rough, because I haven't been to a doctor for anything in like 20 years, other than like sinus issues, and so I got hit with everything all at once. They did the finger thing, where they do that thing.
Wait, explain that to us, Johnny.
You'll find out, Kyle. It was terrible because I've never been through that. Stuff has never gone that direction in that area in my life, other than when I was in Korea, there was a bidet in my bathroom. So that's probably the closest thing I've ever been to that sensation. But yeah, they make you turn your toes in, bend over, so violated. I got my damn pneumonia shot. I've got an AARP subscription for real now because I'm a registered. So I'm falling apart. I'll see if I can get some good pictures of the procedure tomorrow. We'll put it on our website.
Yeah, I really look forward to those text messages.
Yeah, so this is the next IPC
Inside
study, right? Yeah.
We got a burger chain out here called In-N-Out. Yeah, the worst name ever for a food organization.
Cool. Well, a lot has happened since our last podcast, and so we're going to start being a lot more frequent with this. Lots of papers. Talked to Brad Lambert the other day. The ACL Methodist studies finally accepted. I think it's Sports Health. Been talking about that one forever. So it's cool. His baseball college pitcher study is out with interesting results. Maybe fastballs got faster, but he won't fess up to that, although it is in the paper itself.
Yeah.
We've got a heart failure and COVID paper in review right now, Frontiers in Physiology, with some initial pilot data. We've got a sarcopenia review paper in review right now. We got too many book chapters to freaking talk about. Kyle reminded me of one the other day we'd worked on and totally forgot about. I think I have 4 different chapters coming out. So stuff's crazy. If you want to hear a recent pod, I think all of us have done several, but I did one for the Journal of Arthroscopy. So again, it's kind of from an orthopedic surgeon's take, and I think that's a pretty good pod. So go to our website. I think it just came out recently, and we put it on there. So anything you guys want to plug or think about before we roll into these papers?
No, we're pretty boring, Johnny. I think.
Anyone else? Anyone else
going
to be presenting at a conference in Lyon, France in June?
No, we're not, Johnny. We sure aren't. Yeah. So enjoy the travel. I'm sure you're in for unless you got some ways to build your chronic load there.
Well, I'm just trying to learn where's the bathroom and more wine, please, in French. Those are going to be my two sayings. All right, so we'll roll into this. So the first one is from our friends out at Connecticut Children's. And so if you go back, I should have got the podcast number, but in the earlier podcast we started talking about, can we do blood flow restriction in pediatric patients? And so there's a trial going on right now at Connecticut Children's. There's a trial going on at Andrews Children's in Dallas. There's a trial going on at Atlanta Children's. Is Texas Children's been? Are they doing a trial as well that you know of?
I don't know if they have any registered trials going on. I know they've been doing it a fair amount. And when I was over there the other day, I told them they needed to push some stuff out as well. So hopefully they'll get some publications going.
Okay. There's no published papers with BFR in pediatrics. And so that's always a barrier. Kids' muscle pretty similar to adult muscle, although theirs just responds way better. Nothing heals like youth, but you have to do the safety study first. And so good on Adam Weaver and those folks out there at Connecticut Children's, because they first did, is this safe? And also, is it even feasible? Will little kids do it at all? Because like I said, my daughters are wussies. When I try and put BFR on them, they're like barbecue chickens freaking out and get it off. So they can't do it. But this paper did apply it on kids. The average age was 15. Spanning from 12-year-old up to 18-year-old. They started blood flow restriction after quad tendon ACLs on an average of 8.7 days out. So about 8 to 9 days out is when they started it, which kind of lines up with what we're seeing with all these trials. Started within about the first week to 10 days. And they did it on 29 kids, which is fine for a pilot feasibility study, just so we can look at, were there any side effects, were there adverse events, and was it tolerable? And I think what's cool is they logged how many sessions were done. So on these kids, they did 535 blood flow restriction sessions. And so from that, they wanted to look at two major adverse events, which are kind of some of the common ones. One, did they cause clots? That's big question for everyone. Did they see any DVTs that occurred from this? And then was there any sort of vascular damage that might have happened? So was there any sub-Q hemorrhage that they noticed within the limb or under the cuff? And both of those was a big goose egg. So didn't see any signs of clots, didn't see any signs of sub-Q hemorrhage. So their major adverse events, there were none. Their second was, were there any minor side effects? And so really the only minor side effect they had was itchiness, that folks had some sort of kind of itchiness when they did it, or these kiddos did, but there was only that 8% was from 2 kids. So it was really only 2 of the 29 that were having issues with it. The second side effect was some lower extremity paresthesia. We'll discuss this itchiness, lower extremity paresthesia, et cetera, about 3%. And then there was one report, I guess, of dizziness, 0.75%. So before we roll into tolerance, let's just kind of discuss, why those minor side effects might occur if people aren't kind of used to that, and if you guys want to discuss anything on adverse effects. So you guys have any thoughts on that? I think getting into the itchiness, we get this asked a lot. So I know, Zach, you kind of looked into this itchiness. Like, why would you get itchiness when you do blood flow restriction?
Yeah, we tend to think it is really driven from a histamine response. Maybe some people are just allergic to exercise. Ultimately what it seems to come down to. And it definitely seems to be more noticeable in some people than others. And I think that's kind of what, Adam and Nick found with this. They had 42 complaints of it, but it was really made up of from 2 people. So it doesn't happen to everybody, but the folks that it does happen to, it seems to be consistent. And it happens, regularly with them. I've had a guy one time, man, as soon as we literally inflated the cuff before even starting to do exercise, you inflate the cuff and he just starts to scratch his leg. So, yeah. Yeah,
I wonder, like my wife, when she exercises, she gets that. She goes nuts whenever she's doing any aerobic. And so I wonder if there's just a predisposition.
Yeah, that was the one thing that we kind of went back to, was ultimately, it goes back to people with general exercise having excessive histamine response just to exercising. And we just kind of thought maybe, BFR may kind of provoke that a little bit more, or, that's when they notice it with us in the clinic.
Yeah. I had a clinician reach out about it with someone who it really was driving them nuts when they did it, and asked if they should take antihistamines before they come in and do BFR. But I was like, well, they might be just passed out on the table if they do that. So we don't know. I think also we see this purpurea and petechia as well, where you get these little spots. So I like itch. Who cares if you itch during it? Just deal with it. But I know one patient that was being seen out in LA was kind of worked up because this petechia had lasted for several days. So I don't know. Did you see, like, when you were looking at that, was that petechia something that we see? And petechia is like, you get all these little bumpy red spots on your leg. Is that something that we think would be a histamine drive as well?
Yeah, I mean, I think it potentially could be. And in my experience with it, I've never had a patient with it. I've had it during the labs, like teaching a course, and I've had people reach out about it. And when it comes to in the course, I would say it's pretty much almost all resolved by the end of the day. Nothing really has lingered. And then the one therapist that reached out about it said roughly 80% of it was gone by the end of the treatment. So again, it could, be a histamine response. Something is getting provoked and then it's kind of there. And then once you remove the stimulus, it resolved.
Yeah, I went down that wormhole trying to figure that thing out.
It was at George's place, right? Your old clinic.
Yeah, my old clinic. But and it wasn't the first report we had of that going on. And every report prior to that, and including that one, I came to find out is that it was a one-time thing. Like it did not occur a second time. So if you see that, it's been our experience at least that it does not recur. And there was a little bit of literature just like from the tourniquet side, maybe kind of pointing to some capillary fragility or something like that, if I remember correctly.
Yeah.
And they were thinking they were like these little small kind of hemorrhages. But doesn't seem to be like something that is concerning for like an underlying condition or anything like that. Best we could figure out, at least so far. Certainly, more to be figured out on that front as well. But
yeah, I hadn't seen as much on what I would think of as a true petechia kind of response. I mean, it's typically more of the really short-lived kind of splotchiness that's so different and individual from person to person, depending on. It seems like, the folks that have more fair skin, then you end up getting a little bit more of that discoloration or splotchiness that shows up during BFR. Definitely seen some of that itchiness, but not real consistently. So,
yeah. Well, if this is the biggest problem they had in kids doing this out of 535 sessions was a little bit of itchiness in 2 of them, I think that's pretty dope from a safety profile. The other one was the lower extremity paresthesia, and about 3% reported that they did have this kind of paresthesia that you get. And that's common. And I've had some people say, well, you talk about tourniquets, one of their big concerns is potential nerve damage. And you're saying it's okay if while you're doing it, your leg and, it's a lot of times when I do it, the bottom of my foot goes numb. And so that's okay. And so have you guys talked to anyone about that or have people come at you with that?
Yeah. I tend to look at paresthesias as kind of a graded scale almost. Like tingling, I'm okay with. Numbness, not so much. We need to deflate the cuff. And when with the tingling, I always tell people it's more of a subjective complaint, such as how bad is the tingling? Is it really bad or is it just tingling a little bit? Because, and then the final question is, where is the tingling at? Almost always it's on the whole distal aspect of the limb, whether that be the hand or like the lower leg. If that's the case, I'm probably thinking the tingling is a result of the reduction of blood flow versus the compression of a nerve. Versus if they would say, oh, it's in such and such place, and that follows more of a dermatomal pattern. At that point in time, that would indicate to me that, we're maybe compressing on a nerve and we need to either deflate the cuff, decrease the pressure, or shift the cuff, move the cuff around.
That's a great point. I've never seen a dermatomal pattern as well in anyone. It is almost always lower leg or my hand. And usually it's the entire hand. It's not. My third and fourth or something. Yeah.
And then, on the clinical side of things, I believe we have 3 papers out, 2 of which are PhD thesis papers that have specifically looked at nerve conduction velocity, whether it be the H reflex or the M wave, and we see no altered nerve conduction velocity. That's just kind of when it comes to the paresthesias. I tend to think as well, it's not too much of a big deal. As long as we're not getting something in a dermatomal pattern, and as long as we don't have all out numbness.
Right. Yeah. And that's, we always want to put this out. Best tourniquet guidelines are use a wide cuff, a wide tapered cuff.
Yeah.
It requires less pressure and that really keeps the nerves happy. We avoid these pressure gradients. The more narrow you start to get with these cuffs, The higher the pressure gradient, looking back 10 years of tourniquet use in the battlefield, the number one disability driver from it was nerve damage, because in the battlefield, you have to use these real thin, narrow cuffs. But you see clinicians using real thin, narrow cuffs all the time. They just probably don't take the pressure up high enough to be too dangerous, but that also means they're probably not really doing BFR.
Or like a wrap or something like that. I mean, I have, concern over those things too, because you end up with potentially a pretty narrow gradient with that as well, so something that anything you can do to reduce the amount of pressure you're delivering to that limb it's inherently going to reduce risk and probably, I would say, reduce perceptual responses and things like that as well, which is certainly kind of go into, well, is it tolerated? If it's not tolerated, then at some level, the responsibility is on the clinician to make it tolerable, that's our job. That's our skill. That's what we get paid for. So do your work,
Yeah.
With these paresthesia kind of sensations, I mean, it definitely seems a lot more frequent on upper extremity than on a lower extremity. For me, the times that I've seen it on lower, I almost wonder if there's something positional as well. I see it more so if somebody's sitting off the edge of a table, if they're in a dependent position. I wonder if just that itself also affects it, because you don't see it when somebody's on the table doing bridges or straight leg raises, something like that, or at least I don't typically see that.
Yeah.
So
that's the one trick. That's the one trick too, Ben. Even in the upper extremity, my experience with it is it almost always happens like during a prone exercise, such as we'll say like a prone abduction, and it's during the rest period.
Yeah.
Whenever they keep their arm down, before even changing any of the parameters with the cuff, the pressure, the whatever, I just have people put their arm and rest it on the table above their head, and that will either almost always make it tolerable or significantly better, or it gets rid of it completely. So it's really when the arm or the limb is down that I've noticed it.
Yeah.
And when we started at the DOD, we were using 80% pressures in the upper extremity. So we were causing a lot of hypoxia, and people's hand they could barely hold on to the weight anymore. And again, it wasn't dermatomal. It was just like, man, my hand is like tingling and going crazy, and I can't hold on to this. So thank God it seems like 50% works, or we wouldn't be able to get a lot of this. So good. All right. Well, that's easy. The last one, one case of dizziness, not a case of syncope or fainting, but did feel dizzy. And so that's the one thing, we've had it reported and we've seen it, these potential like almost passing out things. Ben and I saw one. We're up there at the Steelers. It was almost kind of scary. This person like going into the syncope episode and almost like a mini seizure type thing. But we kind of figured out, and they did some testing. This person was really, really dehydrated. So it might have just been a reperfusion type effect. But dizziness can happen. And that's why when you do blood flow restriction, especially when you're first started on someone, you got to make sure they can tolerate it, be there around them, because on cuff deflation, when you get reperfusion or just while they're going through it, we think it's probably more of a vasovagal. And athletes have a higher vasovagal response. I had a NHL hockey player pass out. It was probably because he had a PRP done, and he said he was afraid of needles, but we were doing the BFR and PRP kind of protocol with him. So any other thoughts you guys have on that dizziness or potential syncope?
Yeah.
The other surveys that have been done, sorry, Ben, that's been reported globally. So that is something that we all need to be aware of. It seems like every clinician has, if they do this a lot, has potentially seen that.
Yeah, I mean, I was just going to say the times that I've seen the dizziness, I definitely have to think that dehydration is a factor. I mean, for one, I just assume everyone's dehydrated, but also, I mean, I've seen it more frequently in students than anything else. It's like I probably haven't had enough sleep, been up drinking too much coffee, studying. And then, people are holding their breath while they're doing exercise, like they're powerlifting, and all of a sudden you get dizzy toward the end of that. So,
the very first presentation that I ever did on BFR was with Ben at Hardin-Simmons University, and the first person we put it on, God, got dizzy and nearly fainted on us. And we were looking at each other like, that's never happened to us.
Yeah.
So, but then we got talking to the girl. She hadn't had breakfast. She was hopped up on coffee. And it was just kind of like, okay, well, he probably didn't have any business doing any kind of exercise at all.
Well, that's what happened with Ben and I. It was the first one up there. And then we get down, we're like, okay, cool. Who's next?
Yeah, who wasn't doing next?
It's a great way to start a lab, man. It's like, okay, the first person just passes out on us. It's like, all right. We swear this is safe, guys. Like y'all should try this.
I wanted to ask y'all, because I was looking at their methods and kind of thinking about, how many, because I when I was looking at the numbers, I thought it actually kind of surprised me how many how many instances of like the numbness and all these different things that they had. But I think in looking at how they did things, they were gathering that data after every exercise that they did. So you had 3 data points for every visit because they were doing 3 exercises. So it's super curious to know if those 2 people that were having the numbness, right? That was what we were talking about, the numbness. That was the 2 people, I think. Itchiness. I'd be very curious if it was kind of like those first few visits and then it attenuated, or did it have something to do with the change in exercise or change in load? Did those things kind of affect it as well? So that was just kind of a thought I had, and just sort of looking at how they went about doing this paper and capturing that information. So,
well, I think overall we can say from a safety profile from 535 sessions with these 29 kids, we see nothing at all that would say don't do it. So the next thing is the tolerance profile. Can kids even do it? Average age 15, and so only 3 basically tapped out of those 29 and weren't able to do it. And so, that's probably kind of aligns with where we're seeing it in the adult kind of population as well. Getting this kind of tap out effect. And then about 3.5%, they just had to lower the LOP. So any thoughts from you guys on that?
Yeah,
pretty straight.
They in the when they talked about like the failure or the inability to finish, they noted, like in the discussion aspect of it, that ultimately they included in that the people who failed as a result of the exercise, so failed within, say, the 3rd set of 15 and whatnot. So potentially that initial number of unable to complete may actually be an overestimation of kind of a precaution type of a deal. It may just be the effect of the exercise. Which is ultimately kind of what you want.
Exactly. They pointed out in the discussion. I was like, that's kind of what we're going for here.
I was gonna say they need to get those numbers up a little bit, I think, just to make it to where more people can't finish all 75 reps.
They hit fatigue. Perfect. Cool. And I think going back to your point. Oh, go ahead, Kyle.
No, it's all right. Go ahead. I'll jump in after.
Getting back, we didn't really go into their protocol, but it's pretty much standard if you follow us or if you've been trained by us. 80% LOP, which was good and interesting. They used a high pressure, and these kids in general, they only had to decrease that pressure in 3.5% of them. So you're talking a little over a week post-op ACL, and they're going right at it and hitting an 80% LOP and 3 exercises, and so that ain't easy. And they progressed them. So they started kind of with the basic exercises and then started getting into things like leg press. So each week they progress those exercises. And if anyone's ever done 3 BFR exercises at 80% LOP, you're smoked. That's some serious work. So good on these kids for being able to do that. And then of course they followed kind of the same thing, 30, 15, 15, 15 with 30-second rest periods. So standard kind of protocol, but very tolerable for all these little kiddos. So, and I guess point out, everyone's always, how do you find your 1RM for this? They use the OmniRes scale. And I think we've talked about OmniRes enough, but it's an RPE scale. You can go to PubMed and just put in OmniRes. It's been validated. There's several papers that have looked at it. So instead of finding a 1 RM, you basically have your folks do the exercise and tell you where that's at around a 2 or 3 on an RPE scale. And that's a good starting point. Cool. Any thoughts on the protocol? Pretty straightforward, right?
Yeah.
Cool. 50-50 split, male and females, which is great to see in the research pretty much. And overall, you can say that 90% were able to do it. They did point out in their intro, I didn't know this, there's a 35% re-injury rate in pediatric ACLs. That sucks, that's high. And so that's their reason for adopting blood flow restriction there. And I know a lot of the other institutions, obviously that's why we do it, because kids getting their quad strength back, their thigh strength back is huge to their recovery. Any final thoughts on this study?
I did like in their discussion, they said BFRT pressure, duration of inflation, and cuff width are 3 modifiable variables that may influence the likelihood of adverse events with BFR. I mean, those are 3 things that we as clinicians can manipulate and change to gradually expose someone to this intervention and beginning early and kind of getting where we need to get. I think we hear a lot just from the talking heads, if you will, that, oh, this 80% pressure, people can't tolerate it and this and that. I'm like, no, garbage. That just tells me you're not being a clinician. You know, you need to be modifying these things that you have the ability to modify and eventually get your patient to the point that they can perform this exercise in a way that we know leads to adaptation ultimately. I was also a little troubled in their analysis. Their analysis began with results were analyzed using Microsoft Excel. And
you're triggered.
I know you're triggered. I can't. I have a hate relationship with Microsoft Excel and Adobe Acrobat, and it was hard for me to read on after I read that, but I powered through. So I just wanted.
PTSD is real, Kyle. It's a real thing, man.
I believe it. I got it from
yeah. Anytime we have Kyle do anything, we say, "Can you put that in a spreadsheet for us?" He basically gets one of those syncope episodes we were talking about earlier.
Yeah.
Fill them out.
See him curl up into a little ball. Yeah.
Well, and so this was a safety study, and again, great on these folks and our friends there for getting this out there. First published BFR PEDS paper there is. And so it looks like it is safe and tolerable in at least this age population for post-op ACL. Again, you've got all those variables that you can control for in this. And so their next phase is they're continuing with their clinical trial. And so we are waiting, excited to see what their results are going to be now, looking at outcomes and with strength and things like that, and function and pain. And they kind of, I saw on social that I think Adam or someone kind of teased, we're already seeing a 30-something% improvement in strength scores versus control group. Did you guys see that?
I didn't see that.
Yeah. Because I was like, well, did you already publish that paper? Is that coming? But it looks like maybe they're already trending in the right direction, which is fantastic. Cool. If you use Delphi systems, these cuffs are rated for pediatrics. They're rated for pediatric surgery. So these cuffs are also, they're not just for adults that we use. They can be used in pediatric situations, and that's what they used here. All right, cool. No kids freaked out. Only got a little bit of itching. No big deal, man. Just scratch, my little man. Scratch. Keep going. Hope you don't get some petechia. All right. The next paper is another follow-up one, and this is a survey study. So if you listen to our podcast that we did on MS, multiple sclerosis, with Dr. Managgio from University of Colorado. I'm just going to say Mark because I probably butchered his last name.
Maniago. It's the Inya.
My Spanish, man. I'm going to be in France. I'm going to be falling apart because I can't even speak Spanish. This was a survey on BFR practitioners and do you use BFR in neuro populations? Again, there's not enough neuro studies in blood flow restriction. So what Mark wanted to do here was get just a general kind of consensus in the clinical landscape of, are you guys using it in this population, and do we need to start doing some more research to make you want to do it in this population? I'm on it as well, and Mr. Kyle Kimball's on this as well, man. Congratulations. What is that,
number two? Number two.
And your research gate, it's probably like 0.5 right now.
Yeah. I don't even know how to get one of those.
Yeah, you might have to wait a little bit.
Probably.
I bet you could now, having a couple published.
Really?
So, yeah, I'll
send a request. Be like, please, may I have a research gate?
The good thing on ResearchGate is you can get some of these papers early. You know, the clinicians researchers will put their stuff out there, and you can request for them to send it to you. So cool. All right. So this was not the largest survey done, but not terrible. It was 112 BFR practitioners were surveyed on their use of blood flow restriction for neuro conditions, and asked them, are you doing it? Who are you doing it on? What's the problems that you've seen? What are the kind of outcomes that you've seen with this? And so out of those 112, 89% said that they thought that BFR would be at least safe to do in neuro populations. So about 90%, which is interesting. We have a really large survey study we just finished. That was Dr. Brendan Scott out at Murdoch University in Australia was the lead on it. Stephen Patterson's on it as well. And that number is completely different when you're looking at this from a global scale. So this is just the United States. So, we've adopted blood flow restriction clinically, I think, more than most countries. And so maybe we have people that are a little more, kind of accustomed to do it and feel comfortable doing it on people. The hypothesis was set that 25% of the people asked would say they are doing blood flow restriction on patients with neurologic diagnoses. And so what they found out of 112 was not only 90% say, yes, we think it's safe, but 38%, so around 40% said, yeah, and we're doing it on neurologic patients. The most common use for blood flow restriction was to use it for resistance training in neuro populations. Number two was using it for aerobic training. And then we can go into it here a little bit. There was about 10% or so of all these other uses, using it for functional training, balance training, passive use, etc. The most improved outcome that folks saw was improved strength in these people. And then just really no adverse effects at all that were really reported. There were some minor side effects. So the number one side effect in neurologic populations was that they couldn't tolerate the LOP. Again, that's a modifiable thing that you as a clinician can do. The second one was that there was severe fatigue in 5 reported episodes. The third was there was severe pain. And then the last one side effect was that there was some severe muscle soreness. And Mark used the word severe, so it makes it seem more serious, but that's not a lot there. So really minimal side effect things to really worry about. And the most common report of why you aren't doing it on neuro or what would you want to see, and 63 of 112 people said we would like to see more neuro research. So that being said, and we can break down the different types of neurologic uses of blood flow restriction, which some of them were kind of interesting to me. But you guys start rolling in of your thoughts on this.
Yeah, I mean, I think that I think there can definitely be a use, and I know Kyle has said this before. It's something we talk about in the course as well, is getting away from this idea of, does BFR work for a given diagnosis? You know, in the grand scheme of things, it very well might help with specific diagnosis, but then you have to look at the whole picture. You know, one of the MS trials that's out there is literally just looking at gait speed, and you know, can we do walking on a treadmill at a relatively low intensity over a 6-week period, and then detrain or just stop training and do a follow-up 6 weeks later. And what we see from that is a 0.12 meter per second increase, which I think to a lot of orthopedic and sports medicine folks, That doesn't sound like a significant increase, but there was a study done in 2020 out of University of Pittsburgh by Schumann. And what they showed was that for every, what was it? Point
one.
No, it was less than that. It was because it was a point, 0.06, I think, is what it was. It led to an 11% decrease in fall risk. So that study showed that there was ultimately about a 20% increase, or a 20% decrease in fall risk. And then you take a look, Annie Bain's paper that she did with Parkinson's folks,
which is finally submitted. Sorry.
Yeah. So, and what she found after 4 weeks of training was about a 90-foot increase in a 6-minute walk test. Again, doesn't sound like it's kind of over the top and whatnot, but that same paper from Schumann found that for every 20-meter increase, which is roughly 66 feet, again, there was an 11% reduction in fall risk. So, it's a pretty huge thing that you're able to kind of achieve. And specifically with the MS trial, was that result was sustained once the training stopped. So 6 weeks after we stopped training, they still maintained that increase in gait speed.
Yeah, it's huge. And that 0.1 meters per second, I think Colin and I were hitting on, was the mortality risk. Was significantly increased.
Yeah.
And so if you're saying, man, all I got to do is have an MS patient walk on a treadmill for 15 minutes with blood flow restriction over 6 weeks, and they increase their gait speed by 0.12, now you're touching on mortality risk. And that's like the easiest protocol in the world. Like, come in here and walk on this thing for 15 minutes. And so again, we get hung up sometimes. I'm like, well, can we do this on MS patients? They got a lot of the same, kind of physiologic things that anyone does. I think the big concern everyone had was the fatigue. And would you get this kind of MS kind of rebound type effect where they're really wiped out for days? And it seems so far like that hasn't been a thing.
Zach, have you had an older person walk with BFR on the treadmill? Have you done that before?
Not walking, the bike, yes.
Yeah.
We do a lot more with the bike in the clinic with older folks, but we've done it. Yeah.
Yeah. The treadmill makes me nervous with older people, period. But the bike doesn't make me nervous at all. It'd be a really interesting study to just take older persons or persons with neurologic conditions or something and just do like interval cycling and then see, does their gait speed improve or does their 6-minute walk test improve? That's a simple study. I'm just throwing it out there. Anybody can freaking do it. If you're a PT student and you listen to this podcast, I don't know why, number one, you listen, but number two, hey, there's a great study for you to do. Super easy, as long as you can find a bunch of old folks to squeeze their legs and make them pedal a bike. But
I'm older and I've walked on the.
Yeah, Johnny, you want to be in a study?
It was no big deal. I've got an ARP subscription. I can give you my membership
and a colonoscopy receipt to prove it.
Exactly. So, no, great points there. And so the most common used neurologic conditions that people reported using BFR on were spinal cord injuries and MS. And those are primarily two of the neurologic things that we do have some publications on. So there is some research to maybe help back that up. Probably the most published in neurologic is the idiopathic myositis, the inflammatory muscle wasting diseases. But Mark made a point, because there was only like 4 people who said they've used it in that, but I've never seen one of those patients. I've talked to a lot of them. I've talked to their society to try and get a grant for a study. But he said most clinicians really don't see those patients a lot. So that might be why the most published group we've seen is just because that's where, the special research has gone. So just want to go into the third one was TBI, which was interesting, that people had reported using it with traumatic brain injury. There's no publications on that yet, although there is a concussion study. I don't know where they stand with code and everything, but Duke, it was doing a concussion study with BFR. Our trainer out in Australia, Adrian Sexton, he has done a lot of clinical work with BFR and traumatic brain injury, and has seen some really positive results. And he's presented that out in Australia and in some conferences. So I think that could be a good population. Then the fourth was stroke. The fifth was Parkinson's. Inflammatory myopathies was after that. Then muscular dystrophy, cerebral palsy. And then 3 people are reported. I thought that was really interesting, the ALS. And so I've had that question quite a bit. Have you guys seen anything in ALS with this? And so they're just so debilitated. I'd be interested to see what they used on those folks. Was this a passive application, passive with BFR? Passive with NMES. Any follow-up or thoughts you guys have on those different diagnoses?
I think I would just kind of go back to the point Zach made and that I've made, is that, we kind of want to just really think of these folks as in need of adaptation and muscle, and, how can we get BFR to do that? I think too often we'll hear maybe a comment like, well, they're not going to be able to keep whatever they get kind of thing because they don't have the communication or the function in their nervous system that a normal person might have. But I think, like the MS trial showed, the pendulum swings too far with muscle a lot of times. And so we need to kind of bring it back. And in the end, last I checked, we're still doing rehab with these people. We still see some value in that person coming to the clinic and doing these things that we're having them do that don't cause adaptation in muscles. So I really kind of, in many ways, see a ton of upside for neurologic conditions. I know just standing by this poster at CSM, I had a bunch of people come by that had actually been using it in people with neurologic conditions already. And in most cases, it was kind of an overflow from their association with their orthopedic clinic where they had started using BFR, and the conversations just kind of start happening and like, are y'all doing this? Maybe you should kind of think about it. One of the things that there's an individual, he's come by our booth like 2 or 3 times now at CSM, and he works a ton with spinal cord injury. And one of the things he was saying to me is they're seeing pain reductions in these people with spinal cord injury. And I don't really know that's the right word I'm looking for. The incidence of pain in persons with spinal cord injury, like how much pain do they deal with? Is it something that we even recognize clinically as something that we might, have some interventions for or consider treating in that population? Do y'all know, have y'all had an experience with that? I have not. So no.
I don't see those patients enough to know, and I haven't talked to anyone other than our friends out in Colorado.
Yeah, I haven't either. And I actually had somebody pose the question to me the other day, would this be beneficial for somebody who's had an amputation and has some of those phantom limb pain type sensations? Would that kind of fit into the same category here?
Yeah, we get asked that a lot, because at CFI, we had so many amputees, but we were doing it way more on limb salvage and sports problems than the amputees. And so I don't think we ever did it on someone with phantom limb pain, but
right. Yeah. I mean, I don't,
that's a giant black box, man.
Right.
We need to at least try it.
Right. Well, I mean, I remember applying it to the limb with the amputation for, some strength gains and using it, just not inspecting any potential changes for pain or sensation.
Yeah. Yeah. We did it with some of the complex regional pain syndrome stuff. And it was like a 50-50 mix because we had so much of that with blast trauma. Some people they're like, hey, it kind of helped. And then, we had some who were like, dude, it made it worse. So we don't have enough probably to know. And that was just a handful of them that we did that on. So going back, again, it's a survey. This is retrospective in nature. And so, take it with a grain of salt. But reports of VTE or DVT, 0, syncope episodes, 0, severe swelling, 0, severe skin irritation, bruising, 0, sensory changes, paresthesia, 0, rhabdo, 0, fall causing injury, 0, abnormal shortness of breath, 0, abnormal change in heart rate or blood pressure, 0. So the kind of major things that you might look for in these type of these type of patients, no one reported seeing that in at least the people who had done it on some neurologic patients. The two diagnoses where people said, I am the least comfortable doing this on would be the ALS and then the inflammatory myopathy were the two where people said, yeah, I need some serious research before I start doing it on these populations. So I think if you're interested in this, we are very interested in this. So we've done pods with Mark on MS and his MS trial. I'll point out there as well. I'm like, I forgot what my title is. I'm like an advisor for him for this or something. He did win the Young Researcher Award for MS by the VA. So he's getting funded to expand his clinical trial, which is awesome because it seems like he's getting some pretty positive results already in the pilot that he's doing. We've also done a podcast with Dr. Annie Bain, whose paper we hope comes out on Parkinson's disease. And that is a fantastic study as well.
We haven't had Annie Bain on yet.
Oh, we didn't?
We keep thinking that we have had her on because we've talked about her so much.
We talked about it.
But we're going to get Annie Bain on a podcast one of these days.
She's a busy young lady.
She is.
She's fantastic.
She'll be a fun interview and she'll be cool for everybody to hear. Mark's going to be on a podcast, by the way, Johnny. He's going to be on an APTA podcast. I think it's I don't know if it's the Neuro Academy has a podcast or if it's just the main APTA, but he emailed the other day and said that he's going to be doing that. So, if it's out, if I can find it, I'll just link it in the show notes, but we'll obviously tweet it out and post it when that comes out too. So,
and we've also done the spinal cord injury podcast as well with some clinicians or some not practitioners, but an owner of a nonprofit who they're using it a ton out there in Denver. So if you're interested in a little bit more neuro and how people are doing it, we do have those out there. There's quite a few trials that are starting to ramp up in these populations as well. And so I guess putting a bow on all this, a study that looked at safety in kids looks good. They can tolerate it, looks safe, no reason other than a little itchiness. And then at least a survey in practitioners who have done BFR on neuro patients, the general safety profile looks really good. And also, one of the main outcomes that they saw as improvement was they did see increase in strength in these individuals. Any parting shots? You guys make it, Ben and Zach. I know you haven't done anything like this podcast in a while. Y'all good?
Yeah, it's nice to be back, get the podcast legs back. You need to get you out there on more courses, I guess, get your course legs back.
No, I'm good.
You go to France for a conference and we'll just keep teaching courses and
yeah, you guys do that. I'm gonna pick international conferences. I'm done with America.
No, I mean it is really cool to see these studies come out for this survey study. It's nice to see that some people are willing to branch out into some of these populations that don't have publications, because we do get that a lot where it's like, I don't know, there's nothing on it. And I tend to fall back on the conversations that I know we've had with Larry Cahalan on the muscle hypothesis for some of these patients with cardiovascular disease and things like that. Well, it's we kind of still need some muscle in all these folks as well. So maybe just falling back on that at this point in time until people have enough to make them feel comfortable. And I don't know that we're ever going to have these things for all these diagnoses. So going back to Kyle's frequent point of this is not a diagnosis treatment.
Yeah. Awesome. All right, boys. I'll make sure to get you pictures from the outside and the inside.
Great. We're
ready for me tonight when I start taking my poop pills.
Now I know why we don't have a meeting tomorrow. I figured it out. I've connected the dots here.
I'm gonna be laying there with my tongue hanging out of my mouth.
Yeah. We should have scheduled this for later so Johnny could have done the talk from the porcelain throne.
I'm sure the acoustics are good in there.
All right, boys.
Well, that was an awkward end to a podcast.
Yeah.
All right. Signing off.
As always, thanks for listening. Go to owensgravityscience.com if you want to check out our courses or content. All of our podcasts are on there, including that new general arthroscopy one that just came out. I think it was pretty good. I got some good jokes in, I think. That's all that matters to me. All right.
Like, share, subscribe, all that crap.
Yeah. All right.
Bye.
Thanks, fellas.
Yeah.
Talk soon.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.